At OnlineMedEd, we walk you through every topic in detail, so you're ready for the boards and the wards. Neurodevelopmental psych is going to cover those disorders which aren't going to be confused for each other, but have this general umbrella of kids not behaving or developing properly. Either they're having trouble in school later on, or they're having trouble developing the social or cognitive skills that they're expected to. Let's break it down one at a time, spending a lot of time within each diagnosis, and we won't really compare them against each other. The first one is intellectual disability disorder. In the DSM-5, mental retardation is no longer a thing. It's not even a word you should say. Intellectual disability disorder is what we call it. And in this disorder, you have a decrease of cognitive skill. The child loses the ability to have complex thought processes or to handle higher order functions, like doing math. And they also have a decreased adaptive functioning. They need help from family or support staff. Intellectual disability disorder is going to be encountered in three ways. The first is genetic screening. This is prenatal screening for genetic disorders that might predispose the child to intellectual disability. And the learning point here is if you are going to do genetic screening, you must be willing to terminate. The only reason to put mom through the genetic screening, which puts baby at risk if you go the full gamut, is to terminate. Because if you know they're going to have intellectual disability disorder, but you're going to give birth to it anyway, don't put mom or baby at risk by doing the testing. So if mom is worried about this disorder, she can get genetic screening, but she must be willing to terminate if you're going to start. The second way you're going to see this is part of a syndrome. Right? Mom didn't get the genetic screening, babies come out. Disability disorder is associated with things like Down syndrome, Fragile X, and Cri-du-Chat. The third way you're going to encounter intellectual disability disorder is in the acquired forms. And baby might be born normally, but acquire intellectual disability from, say, lead poisoning. This is after being born. Or mom could acquire it for baby by drinking during pregnancy or by having hypothyroidism leading to cretinism. These are both in utero causes. The diagnosis is clinical. We used to use a scoring system, the IQ test. It's still useful, but it's not diagnostic. The IQ test was a standardized examination. The mean is 100, standard deviation 10. If you are 3 standard deviations below the mean, it meant you had mental retardation. I'm still going to link IQ scores with function in intellectual disability disorder, but it's no longer the right answer on the test because we don't use IQ tests to diagnose the disorder. Instead, what we do is see, hey, how severe is the disorder, and we put that proportional to the loss of adaptive function. It's not about do you have the disorder or not, it's how much care do you need. Once you have it, there's no going back, so there's really no treatment. What you can do instead is create special education classes that trains these kids at their level and create some social skills. Because they very rarely progress beyond the mental capacity of a child, they're particularly vulnerable. So you're also going to support them through life by giving them the necessary resources and help to continue their life. I do want to break this down by IQ score and by what approximate grade they get to, and then what of their independent functions have been lost. And you'll see why I like this because it creates this nice chart that kind of keeps things contained. If your IQ score is greater than 70, you don't have mental retardation, and even though we don't use the IQ score for intellectual disability disorder, for this argument, I'm going to say that means that you don't have IDD either, and you can progress to whatever grade you want. In this person, who's effectively normal, they're able to live on their own, work independently, and take care of their ADLs. That means they're able to take care of their taxes, they're able to balance a checkbook, they're able to drive a car and take a test. They live independently, they work independently, and they're able to take care of their ADLs. As the IQ score gets below 70, that is 50 to 70, they have intellectual disability disorder and they perform at about a 6th grade level. in the way of functioning, they lose the ability to live independently, but they'd be able to do remedial tasks unsupervised, and they're able to take care of their own ADLs. Now, they're living at a group home, but they have mostly independent lives. As the IQ score goes down even further, 35 to 49, you'll see that the kid progresses to about a third grade level. And here they lose the ability to work independently. They can do their ADLs, but they'll need constant reminders to bathe, change their clothes, stuff like that. They must live completely supervised. Still worse, 20 to 34, the patient achieves the level of about a 3-year-old. This is preschool aged. This person doesn't require total care, but is going to need help with everything, living, working, ADLs. They basically must live in a home or a nursing home where they can help participate in their ADLs, but that's about it. If you're less than 20, this is effectively an infant and requires total care. So you see the loss of one level of function with each progression down the IQ step, right, and the grades are sort of correlative. What I want you to remember is intellectual disability disorder has no treatment, special ed, social integration, supervision. The only thing you can do for it is screen for diseases that might cause it and then educate parents on how to avoid causing acquired intellectual disability. Autism spectrum has also changed a lot in the DSM-5. And what I'm going to do is tell you the words that I need to say to be PC, but they don't really describe what's going on very well. So I'm going to put them up there, and then I'm going to try to illustrate in a less PC view what a person with autism spectrum might look like. DSM-5 got rid of those other named disorders that are sort of like autism, but now put them into a spectrum of one disorder called autism. The pathology here is that there's decreased social communication. You may not intuitive what that means just yet, but I'll show you and realize why that word has been chosen. And I have to say this, it's very frustrating that I need to say this, there's no association with vaccines and autism. All kids get vaccinated, the vaccines don't cause autism. Autism is a genetic disorder. We don't actually know its precipitant cause, but we do know that it is genetic, and the kid's gonna have it or not. It's not something mom or dad does, it's baby's got it one way or the other. But we know that the disorder is a component of two things. That is going to be impaired social communication and also restricted or repetitive behavior. What the hell does that mean? All right. So impaired social communication is going to be evidenced by 4 different things. Social reciprocity, social relationships, nonverbal communication, and joint attention. Impaired social communication are problems with social reciprocity, social relationships, nonverbal communication, and joint attending. What the hell does that mean? Right, so this is the stuff I have to say because that's clinically correct. What it means is that the kid just doesn't get it. Right? You walk on the sidewalk and not on the flower beds because you walk on sidewalks and don't walk on flowers. A kid with autism sees the piece of paper on the grass, the flower bed, and the sidewalk all the same. There's no emotional meaning to any of those things. They're just a place to put your foot. And so the way this is going to be evidenced in a newborn or someone who's growing up is the inability to socially bond, social pair bond with their mother. It's particularly what parents are trained to look for is eye contact. Right? Social smile, eye contact, sharing of experiences are what normal babies do. They'll look at the object and look at you, look at the object, look at you. That's the shared experience. If they don't look at you, they might not even know you're there. But an autistic kid, more importantly, lacks the ability to understand other people's emotions. If someone is crying next to them, the autistic kid might not even know that they're there, let alone that they're crying or what that crying means. In the same way, nonverbal communication, an autistic child is unable to tell the difference between facial expressions, or they're unable to interpret what someone means when they gesture. So they can understand the words, and they may actually be very intelligent. This can be with or without intellectual disability. It looks like they might have intellectual disability because they don't pay attention or they don't listen, but really they're doing something on their own in their own world. So it's the inability to understand emotion or the having a value of things, which also compromises the relationships, and the way you diagnose that is by looking for eye contact and social smile. Can't understand gesturing, but can understand words just fine, and then has no interest in sharing their experiences. Restrictive or repetitive behavior is manifested in 4 ways. The first is stereotyping. This is what autism is known for. Repeated the same behavior over and over and over again, rocking back and forth, stacking items in a line, whatever the case may be. But importantly, if they're stacking things in a line, they may see just things. There may be no difference between the fire truck, Barbie, and the dinner plate. Right? They don't have the emotional or affective attachment associated with the objects. It's just their objects to be lined up. The other one that most people know about is going to be sameness. Autistic kids need things to be in a very rigid pattern exactly the same way, and small deviations from routine cause great distress. Restricted interests. They get fixated on one thing, prime numbers, stacking, orange markers, whatever the case may be, and that's their thing. They don't care about anything else other than that. And then there's this vague thing called change in sensory perception. The diagnosis is clinical, and you should rule out learning disabilities first and rule out intellectual disability disorder. The treatment, much like intellectual disability disorder, is going to be supportive. Special education classes that train primarily social interaction. These kids may also be incredibly intelligent in one particular field, and so they might actually be very productive, but they're going to be weird, or they're going to be abnormal, what most people are used to seeing and interacting with. And the way you're going to see this is in one of 3 ways. We're going to compare severity to the usual age of onset and what the presentation has been thus far. In the mild form, it may go undiagnosed for a long time, but it's generally older kids, 4 to 6, who then develop what looks like regression. They're progressing normally with the rest of their peers, and then they begin to looks like to regress, where really what they're doing is not progressing as well as everyone else. And the mild form can actually be very high functioning. These are the kids that used to joke about in medical school as being autism spectrum. They're weird, they may not have great social interactions, but they may have gotten what they needed out of their special education training and can actually be very productive. The most common form is going to be moderate, right? Usually we're presenting between 2 and 4, which happens to be right around the time where you start getting all your vaccines, which is where all this vaccine nonsense happens. It just happens to be that autism is detected right around the age where you start getting a bunch of vaccines. Moderate disease will be a plateau. Right? They'll grow normally and all of a sudden just not continue at all. But they never got so high functioning that it looks like regression. And severe forms are going to be those who are present early, 0 to 2, and these never progress at all. These are people who have no social interaction, no social smile, no eye contact whatsoever. Intellectual disability and autism spectrum are the 2 big ones, know the most about them. The next one is actually something that you can do for the kid, and that is attention deficit hyperactivity disorder, ADHD. We don't know what causes it, but we do know the elements. You have to have attention deficit and hyperactivity. Attention deficit is going to manifest in the way of inattention. Hyperactivity is going to be impulsivity. And almost always, if this disorder is real in a kid, it will be in someone who's a problem student. We'll see why. Impulsivity in class is going to be manifested as someone who blurts out answers, even though they're told not to, who interrupts people, or who fidgets and can't wait in line. They can't wait their turn on the playground. They can't wait in line for the cafeteria. They're moving all around, and it looks like they're misbehaving. Really, they just feel this impulsivity. They need to be moving around, and the fact that they can't because of the structure of the school makes them look like they're troubled kids. The inattention will be manifest as someone who talks really fast, is easily distracted, moving from conversation to conversation, topic to topic, and a kid who fails to complete tasks, like doesn't finish the quiz or doesn't turn in their homework. Again, looks like a problem kid who just doesn't want to participate, but really they just forgot about the test because they're over here looking at the rock and looking at that bird out the window. But it's not enough to have impulsivity and inattention. It also must be in the right time and location settings. In particular, you must have it present in greater than 2 settings. That is, someone who has impulsivity and inattention in class, but then goes home and spends 7 hours in front of the TV perfectly fine, does not have ADHD. It's going to be present everywhere. The onset must be between ages 7 and 12, and the duration of symptoms must exceed 6 months. And then they throw in this thing, the frequency must be frequent. Right? So basically what it's saying is that it happens all the time. If you're going to treat it, it has to be so prevalent and around all the time that it impairs the kid's learning. If you find impulsivity and inattention, and in 2 settings, you've made the diagnosis clinically. And the way I like to think about this, there's nothing to do with the 2 disorders, is if you're reading the question and you're thinking, this kind of sounds like mania or hypomania, but it's a kid, that's weird, they're going for ADHD. And if you're going to treat with medications, you're going to use stimulants, methylphenidate or amphetamine salts. But really what these kids need is special ed. And regardless of what your perception of this particular topic is, whether or not we're overdiagnosing ADHD in our schools and over-medicating, I'm still going to teach you what DSM-5 says, which is if you have the disorder, treat with medications. When really what they just need is some special education classes where they're allowed to interact with many things at once. You set up the structure of the classroom to be congruent with their inattention, but still get all the tasks and learning done. But really where you want to go is the parents. By the time you find out about this disorder, the teachers are probably fed up already because they see this kid who's misbehaving. And the parents are fed up because they just can't control this kid. They feel awful as parents because everyone else is behaving and theirs is not. And what they don't realize is that the kid has this disorder. So you need to train the parents on how to handle the ADHD kids, because they probably don't have impulsivity and inattention. The parents don't, but the kids do. So the parents understand the kid's motivation and they need to be educated. And lastly, if you see ADHD, problem kid, don't forget about absence seizures. Treat with carbamazepine, they'll outgrow them. Absence seizures occur with a no loss of tone, but loss of consciousness. And they happen multiple times per day, up to 100 times or more. So what the kid sees is teacher over there talking about carrots, then she's over there talking about elephants, then he's getting yelled at. And in his world, he sees carrots, elephant yelled at when he missed all the space in between. And so he can't concentrate, he's not learning because there's no congruity with how the story is playing out. When really, he's having seizures. So if you see ADHD, but there's something about seizures or carbamazepine, pick absence. Lower yield as we get to the end here. The last remaining is tic disorders and learning disabilities. Tic disorders are just like OCD, and there's an association with OCD and ADHD and tic disorders. A tic disorder is either a physical or a vocal tic. And a person has a tic, and that's their tic. Just like OCD has their obsessions and compulsions. And just like OCD, it's like breathing. Right? You can hold your breath, but eventually you must take that breath. For someone with a tic disorder, they can suppress the need to do that tic, but eventually the tic wins. What you're looking for is any sort of physical movement or vocal sound, usually grunts or coughs, not words, and never swears. So the joke is, I got Tourette's, I can swear all I want. It's always the same word, same motion, or same sound that is that tic. And the person has to be diagnosed with a tic disorder before they're 18 and have a duration greater than 1 year. If you make the diagnosis of tic, which is a clinical diagnosis, you can treat with D2 antagonists. But it's better to do cognitive behavioral therapy. Right? A lot of people who have tic disorder integrate the abnormal anxiety-causing tic into something that's innocuous. If someone needs to flick their fingers a lot, they might just brush their hair instead. And it looks like they're brushing their hair, or fixing themselves all the time, but really it's the flick. And so in using cognitive behavioral therapy, you might redirect the need to do the tic to something more innocuous than the tic itself. Lastly, common things being common. Learning disorders, learning disability. Right? If someone comes in and says, hey, my kid's not doing well, they're a poor performer. Yeah, you do want to consider the things we talked about in this lesson. IDD, ASD, ADHD. But don't forget about the usual stuff. Things like vision and hearing. Does the kid need glasses? Can the kid even hear what the teachers are saying? Is going to be useful because you just give them glasses or hearing aids, all of a sudden it gets better. And you may diagnose some syndrome that they have that needs to be treated anyway, which is why we screen for vision and hearing every time we see a kid. Also, don't forget about this. It frustrates me that I have to say this, but if you're not testing or teaching in the native language of a kid, you can't expect them to learn. Spanish-speaking student shows up in an English-speaking class and he doesn't speak English, he's not going to learn, and he's certainly not going to pay attention either. And then don't forget about things like dyslexia and other learning disabilities, which we're not going to go into in great detail. But I wanted to close off with reminding you that, yes, this stuff happens, but on the test, they're going to be so obvious, they have to be overt about it, they can't be covert, that it's going to be pretty easy to spot these. But really what you should be doing is making sure kids aren't eating paint and getting lead poisoning, having their vision and hearing screened, and make sure that they're being taught in their native language, or at least the language they can understand. Intellectual disability disorder is about adaptive functioning and cognitive skill. The worse you get, the less independent you're able to be. Almost all of these people are going to be in group homes and supervised in some way. The more supervision they need, the worse the disorder. Autism spectrum is about sort of getting it to the social communication, the emotional meaning behind objects or gestures. But what you're looking for is failure to engage in social relationships, eye contact, and nonverbal communication, along with repetitive behaviors. Again, mild, moderate, severe. The more severe, the less integrated to society they usually are able to be. ADHD is the problem kid who moves around, is too impulsive, who has difficult time attending, but it must be in two different settings. Give them methylphenidate and special education. Tic disorders are essentially OCD, but it's one movement or sound they make. And don't forget about vision and hearing. That is Psychiatry, Peds 1, Neurodevelopmental.